It's there. Okay, thank you so much. However advanced we are, the technical hitches will be there. But women with the simple congenital heart disease have very low mortality, but very high morbidity, such as heart failure, arrhythmias, bacterial endocarditis, and stroke during the delivery. So in this background, echocardiography plays a major role in diagnosis, understanding of the pathophysiology, assessment of the associated diseases, and how severe is the disease. And here one has to do both echo evaluation of the mother as well as the fetus. And both are very important because some of the congenital heart disease can be transmitted to the fetus too. And here the not only assessment, we have to assess the associated lesions, the ventricular function, ejection fraction, and how much is the mitral valve orifice, aortic thing, and LVOT. All these things matter a lot. So we have to group them into three. One is the high risk defects, where the cyanotic congenital heart disease, like unrepaired defects, including tricuspid atresia, detransposition, tetralogy of Fallot, pulmonary atresia, univentricular heart, all of them are very, very high risk for delivery. Severe pulmonary hypertension, severe systemic ventricular dysfunction, they are contraindicated for pregnancy. And especially the Marfan's and Eisenmenger's have got high mortality. Now, intermediate risks are the patients who have undergone surgery on unrepaired or repaired AST, VST, coarctation of aorta, pulmonary stenosis, Epstein's anomaly, and the surgically repaired coarctation and tetralogy and Epstein's anomaly. And the low risk are, like I showed the previous, where the ASTs and VSTs are either device closure or surgical closure is done. And those are very low risk for the pregnancy. So this is a 26-year-old lady who had to and fro murmur, systolic murmur. And then when we did the echo, the patient had, oh, sorry, the videos are not playing, the small VST with the AR. Oh my God, the videos are not playing. That was a beautiful thing. Oh, I'm so sorry. So here there is the annular dilatation and then the severe prolapse of the aortic valve causing the AR. And the patient had nocturnal angina. Nocturnal angina means contraindication. That is because the coronary flow is during the diastole, and then that patient can have ischemia, and then during the delivery, the problem can be there. So here, the answer for the pregnancy is no, we have to terminate the pregnancy. Oh my God, none of the videos are playing. I could have given my pen drive and this thing. It's okay, I'll finish it. So this is another 28-year-old lady who had a hypertension during the thing. And then, we saw that there was a flap moving and almost the dissection going right up to the abdominal aorta, lower down up till the bifurcation. This is the 26-year-old lady with 32 weeks gestation, presented with the history of angina. She had a severe aortic stenosis and doming. We did the balloon dilatation and then she went for the normal delivery. This is another achondroplasia. The patient had 178 gradient across the aortic valve, and the obstetrician was scared because the anesthetist was not ready to give anesthesia for the cesarean section. So since both anesthesia as well as the obstetricians were worried, I said, don't worry, I'll solve the problem. I did the balloon dilatation in the morning, and evening she delivered the baby on cesarean section. And for 1 year, she did not come to both of us. And obstetrician and myself, we were wondering what happened. And after 1.5 years, she came back only with another pregnancy. So this is the level of our patients. But however, we have to be smart enough to tell them what is high risk and what is not. And this is a aortic membrane, which is almost like a tunnel. And the gradient was 168. And unless the surgery is done, the LVOT obstruction is removed, we cannot allow her to go for the pregnancy. This is 25-year-old lady, pregnant, coarctation, underwent aortoplasty, and next day she had a normal delivery. So we can cover the abdomen and do the aortoplasty or the balloon, everything. And Epstein is one where the maternal thing is, oh my God, I think my presentation is ruined. This is not good. So this is congenitally corrected transposition of the great arteries, and here the fetal risk is much higher, and because maternal functional capacity is extremely important, and any pregnant woman with the AST, VST is a high risk for this thing. So here it is the patient who had a cyanosis, and the patient had CTGV, VST, PS, and then we did the we told her what is the risk and then terminated the pregnancy. This is a case of double chambered RV with a large VST, and here the very, very risky, and do not allow them to continue. Especially this patient had a non-compaction of the left ventricle, and that has got a high risk of thrombosis, embolism, and arrhythmia during this thing, and apart from the severe RVOT obstruction. So these are, unless we correct, they should not be allowed. So pre-conception counseling is very important. Triology of fallow, there is a pulmonary stenosis, and there is a right to left shunt at the atrial level. And here we can do the balloon dilatation, and the saturation improved, and she had a delivery. So here you can see that tetralogy of fallow, especially operated or not operated, whatever it is, we have to be very careful, because when they do the infundibulectomy, RV is cut, and then they have the RVBB, and they are prone for the arrhythmia, and the arrhythmic deaths are very common. And hence, whether it is the tetralogy with the pulmonary atresia, and so here you can see that it is operated and doing well after the surgery, and she is fit to conceive. The answer is again no. Though she is operated, still she is not fit for the surgery, as she has the arrhythmic thing. And this is the tetralogy of fallow, the tricuspid atresia, 20 years old lady. In the echo, you can see that there is a pericardial effusion, and the LV function is reduced. Ejection fraction is only 54. And any tricuspid atresia with the reduced LV function, they are not fit for pregnancy. So here, this is the 18 years. Diagnosed as mitral stenosis, and echo, it gives a beautiful picture. This is the cor triatrium sinister, the membrane in the right atrium, which Bob Anderson calls it as divided right atrium. And this patient cannot go for the surgery. So the pregnant ladies, we have already heard that this lady had a 0.4 square centimeter orifice. She came with the pulmonary apoplexy, almost hemoptysis, half a liter every day. We did the balloon dilatation emergency in the morning, and evening she had a normal delivery. Under the echo guidance itself, we can do when there is a giant LA, mitral regurgitation, MS, MR, and such a patient, we have done a cesarean section and the MVR in the same sitting in our hospital. So this is how we can treat, and I think time is over. So this is the patient with the RHD, had a bacterial endocarditis. You can see that those are all gas-producing organism. And when there is a Eisenmenger's, you can see that here there is a right to left shunt through the PDA, and this is also contraindication for the surgery. So this is a very, very old one. Nowadays, none of our patients go for this. This is the Eisenmenger's. You can see that we talk about RA collapse when there is a tamponade, but here there is a left ventricle collapse, and this is extremely rare. And as on today, with the facilities that we have, whether it is the echo, surgery, or the intervention, none of our patients should go for Eisenmenger's and for the heart failure. So preconception counseling is very important. To conclude, it's a multimodality specialty. We have to have a obstetrician, pediatric cardiologist, and the echocardiographer, and the neonatologist. All of us should work together to give a better quality of life for the mother and the child. Thank you very much for your kind and patient hearing. And please forgive me for the videos not playing.